Yeah, so again I had to stop because of the silly YouTube. Now we're going to the history where we'll talk about basically what are the important points to come out in the history lah. I know that nobody can ever cover like a complete comprehensive history, but the important things are these points lah. Okay, so the first thing, like I said, is to exclude the easily confused symptoms like odynophagia or globus sensation. Odynophagia is pain on swallowing, globus sensation is lump in throat. So you got to ask them that. The next point is whether it's oropharyngeal versus esophageal. Like I mentioned just now, is it a problem with initiating swallowing or is it a problem seconds after? Mechanical versus neuromuscular follows. You got to ask them whether the problem is with solids or is the problem with solids and liquids. Don't forget that in the late stages of mechanical obstruction, the problem can extend to involve liquids. But a classic of neuromuscular is actually they get more problem with liquids than solids. Yeah. Like of course you know that like those esophageal cancers, right, when they're like really terminal, they can't even swallow their own saliva. So if you see someone in a late stage, right, the symptoms overlap already. The next thing to ask whether it's intermittent versus progressive, because progressive is really classic of some worsening mechanical obstruction like malignancy. I spelled it wrongly there. In the surgical history, it's important to ask whether they had any operations done ever before, especially to the head and neck or esophagus region or stomach, because this can induce stricture formation post-op. Also important to ask whether they got any history of head and neck cancer or not, because they might have undergone radiation, you see. So if they undergone radiation, it can cause radiation strictures. In the medical history, two big categories are very important. Actually, another category that I forgot would be the symptoms of a non-vascular mediastinal mass, you see. For example, maybe if they have been having night sweats, fevers, like a Palepstein fever, lymphadenopathy, that could be like a huge thymus pressing or huge mediastinal lymph nodes like in a Hodgkin's lymphoma, you see. Or retrosternal goiter from a thyroid. So three categories: neuromuscular, vascular, or non-vascular mediastinal mass, you see. So a vascular lesion that could press on the esophagus would be either the aorta or the atrium, as I mentioned. If it's the aorta, you can divide into whether it's congenital or acquired. I didn't write the acquired here as well. Lousy presentation, I think. The acquired will be a thoracic aortic aneurysm like in syphilis or a Marfan's. Congenital will be like any congenital vascular lesion of the aortic root, which produces this condition called dysphagia lusoria, dysphagia lusoria, which is basically when you have any congenital anomaly of your aortic root causing a dysphagia. Just a nice name. Rheumatic fever produces a left atrial dilatation, secondary to your mitral regurg, and then that presses on the esophagus and then they get dysphagia. So as you can imagine, they also probably have like autopnia and so on and so forth, other symptoms of left heart failure. Neuromuscular disorders, CVA, Parkinson's and others, you got to ask that in the medical history. Maybe for you guys in the UK, multiple sclerosis, very important. Drug history, pill esophagitis is not that uncommon, especially in the geriatric population. You should think about it. Common drugs will be like KCl, alendronate, then I guess aspirin and NSAIDs, vitamin C for those who like to pop a lot of it. Okay, physical. Physical won't probably help you to differentiate much of the causes, but it's to look out for the complications as well as to assess for surgical fitness, because sometimes they need surgery. The general inspection, as usual, look out for signs of anemia, cachexia, pallor, look out for the mental state, signs of dehydration, the skin, turgor, and like that. Because actually some of our esophageal cancer patients, I've seen, they really look horrible when they come into hospital. They really look wasted and sick. And then like after you give them like IV fluids, they look better. So make sure that you look out for all these things lah, because then you can adjust your fluid therapy accordingly. The heart, you gotta check, are they in failure or not in failure? Some people may be in high output failure secondary to anemia, you see, especially if they've been having occult bleeds, like from a cancer. Lungs, is there infection? Infection either suggests aspiration pneumonia or tracheoesophageal fistula. None of which are good really. So the signs of infection like the decreased chest expansion, cramps and dullness to percussion cervical nodes, check this to look for malignancy. The abdomen, look for masses and tenderness. Probably won't find any there except maybe for a really huge gastric CA, which usually doesn't cause that kind of mass usually And then don't forget to do the rectal exam, because like I said, if a stomach CA at the cardiac, it can cause a dysphagia, and it can bleed occultly and cause a melena stools. How are we going to investigate this patient? I'll divide into whether it's diagnostic or supportive investigations. For our diagnostic investigations, in oropharyngeal dysphagia, we will look at whether it's a neuromuscular cause or a mechanical cause from the history. For mechanical causes, we will do a nasal endoscopy, especially in this part of the world, because we want to rule out NPC, you see. Sometimes laryngeal tumors also could cause dysphagia if they get really big, but then of course the presenting will be hoarseness rather than dysphagia. For the neuromuscular causes, usually a video fluoroscopic examination of swallowing will be more than adequate. Sometimes they do barium swallows because this can also help to delineate anatomic lesions. For example, a Zenker's diverticulum. Esophageal causes, for mechanical obstruction, you need to do an OGD. Actually, for everybody with dysphagia, as long as it's esophageal in nature, you should do an OGD, whether you think it's motility or not, because of the risk of cancer. Motility disturbance, you use manometry. So manometry is you put in this probe thingy, and then they look at the pressures through the esophagus, especially at the lower esophageal sphincter where they suspect achalasia. If you're thinking of achalasia, you see. Supportive investigations, it can be either blood investigations or chest X-ray. For the bloods, we'll look at the FBC, look for signs of anemia, signs of infection like leukocytosis. Important to look for anemia because it could be and leukocytosis. All these things increase your likelihood of whether it could be a cancer or not. UV cracks are important, otherwise known as renal panel in some hospitals like NUH. You need to check for electrolyte disturbances and raise urea and creatinine from dehydration and or chronic vomiting, regurgitation, so on and so forth, because they're not tolerating food. So they're going to be really sick, like I said. LFTs, you want to look for transaminases raised because it could be mets to the liver, you never know. Low albumin in nutritional deprivation, like usually a malignant cause. Chest X-ray is important to look out for signs of consolidation. Usually, if there's a pneumonia from aspiration, it will be in the right lower lobe, so look out for your chest signs there, your consolidation in the right lower zone of the X-ray field. Metastasis, you want to look out for cannonball lesions, although because esophageal tends to metastasize to lung, liver and bone. Alright, so putting it all together, here's an algorithm. This is also from uptodate.com, but I do not completely agree with them. They kind of say that if you have suspicion for achalasia or other things like history of surgery for laryngeal or esophageal cancer or peptic strictures, right, or strictures, then you just do a barium swallow and the esophageal manometry first. But I don't agree because there's really a risk for cancer, and so we should really just check it out. And I believe all should have endoscopy, so endoscopy should be up here. That being said, most of the other things are correct. If you're suspecting achalasia, then do manometry or barium swallow. If you're don't forget that barium swallow is not definitive for achalasia. You have to do manometry to show that there's a hypertonic lower esophageal sphincter.